So when you talk about immunomodulatory therapy, you have the therapy that is going to affect your interleukins or your CD20 or steroids, and you have immunomodulatory as like neurosteroids. Let's look at the first group first. The steroids, IVIG, Plex, or tocilizumab, rituximab, those play a role in patients that have new onset refactory status epilepticus, which are patients that are having new onset of seizures with no prior history of epilepsy, with no prior history of brain injury, and then all the workup for acute etiologies such as toxin metabolic, acute brain injury has been negative, or infections, has been negative within 72 hours from the presentations. So in those patients, the diagnosis of new onset refactory status epilepticus is being into place, and in those patients, immunotherapy as steroids, IVIG, Plex should be given early on, which is like 72 hours after. There's a subgroup of NORSE that is called FIRES. FIRES are patients that have the same characteristic, but the only difference or addition to the diagnosis is that they have fevers that have been started within 2 weeks before the presentation, up to 24 hours before the presentations. So in those patients, immunotherapy or immunomodulatory therapies is very recommended. Now, for those patients outside of NORSE, the ones that are not in the NORSE category, we have already used Allopregnanolone in the SAGE trial that showed that it was not efficacious. And right now, there's a study going on, it's the RAISE trial, R-A-I-S-E, that is using Ganaxolone, which is an immunomodulatory therapy that activates or acts in the GABA-A receptors that are outside the synaptic cleft. And this is important to know because these receptors do not suffer the downregulation that the synaptic GABA-A receptor suffers in the pathophysiology of a status epilepticus.